About the basics. And today we have Dr. Biju with us. Dr. Biju is a palliative care physician heading the Department of Palliative Care in Rajagiri Hospitals in Cochin, Kerala. So he's been working in palliative care for around 18 plus years, I think from very beginning days with Dr. Raj. And he has immense experience in teaching. And he has he has been our faculty for many years, and specifically on communication skills, and he has special interest in conversations during end of life care. And I think by these two sessions you will get some answers to what we have been discussing from day one. Welcome you, Dr. Biju. Thank you for agreeing to be a part of this wonderful program.
Thank you, Sridevi. Thank you, Rajlakshmi, for having me over here. And welcome to everybody who is here joining for this program from practically all over the country. And since it's communication is a long topic, we are going to divide this into two sessions. Today will be the first session where we'll be talking about some basic things, the basics of communication. And many of it would be revision for most of you, and I assume that. And the next session, which is on 21st, we'll be talking about specific areas like how to communicate bad news, how to manage pollution, how to deal with anger and things like that. But those are for 21st. Today we'll be talking about the basics. And with your permission, I will start sharing the presentation. I hope you can see the screen.
Yes, sir, we can.
All right. So as I said, today we are going to be talking about basics of communication skills. And why do we need to do that? Because there are plenty of studies, but I like to quote this study, which came up in 1986, very old study, came up in the Headache Journal, and which said that the best predictor for resolution of headache problems turned out to be the patient's perception that they had an opportunity to tell their story and discuss their concerns about the headache fully with the physician during the first visit. So what we need to understand is that how we communicate has an actual bearing on the clinical outcome, because patient satisfaction is a major component of what we can incorporate as part of our treatment, as part of healing. And often good communication leads to better outcome. It also leads to less error. A lot of errors happens due to poor communication, miscommunication, or inadequate communication, and these are completely preventable. And as far as doctor-patient relationship is concerned, which is the primary reason we are here today, it is multidimensional. We all know a good history taking leads to better diagnosis. A good communication will better diagnostic accuracy. And if your diagnostic accuracy becomes good, then you can formulate a better management strategy. But despite your best of intention, best of knowledge, best of skills, if the patient compliance is poor, then you are not going to get a good clinical outcome. There also, effective communication will ensure better compliance. And when there is better compliance, you would naturally expect a better clinical outcome. And when the patients are happy, they are satisfied with your interventions, then your stress level will be less, your team stress level will be less. Think of a situation where you have your patient and families coming and being totally dissatisfied every time they visit, quarrelsome. And think of another situation where there are smiles, there is appreciation, there is gratitude, there is thank you, all of this. So the team, your team will be happy, your team will be satisfied. And as mentioned earlier, good communication skill will also ensure the patient's safety is maintained to a large extent. All of this means less chance of friction with the patient and family. A good relationship is what is going to protect you from litigation or physical harm. No amount of taking signatures on consent form is going to protect you. It is always good relationship with your patient and their family. And what does enhance the good relationship? Good communication skills. And hence, we learn communication skills not to give some kind of a bonus as far as treatment for your patient and family is concerned. We learn good communication skills for our own selfish interest. I underline that we learn good communication skills for our own selfish interest. And if communication is important in building up good relationship, then what is the most important ingredient that goes into good communication? And that would be active listening. Active listening is a very, very dynamic process, just the opposite of passive listening, where you just sit and listen. Active listening involves primarily two things. One, body language, and things that we say verbally. Whenever there is a human to human and verbal part which comes into play. And why do we need to learn body language? Because most often we are not aware of how our body is reacting. What are the messages that our body is sending without we even being aware of it? We are not aware of it. So many a times you may be saying something, but what your body is conveying may be contradictory or not in sync with what you're trying to say. And hence it is very important to understand body language. There are a lot of resources available in Google. Just type body language for doctors. You will come across many, many options to go through. Another reason why we need to learn body language is because body language constitutes the major component of any communication. I underline it constitutes the major component of any communication, be it interpersonal communication or professional communication. Whenever we are dealing with human to human interaction, body language, often the problem is not on what you said. Often the friction point is how you said it. What was the tone of your voice? What was the expression on your face? All of these things comes into play. And hence, today I would like to talk about few points on body language. Obviously, I can't speak in its entirety. It will take a lifetime to talk about body language. But for our today's session, just 6 or 7 points, which are something that we can start practicing, or we may already be doing it on a day-to-day basis. For example, eye contact. Now, eye contact is the point which is the first contact with another human being. Relationship starts with eye contact. Often we as healthcare professionals, whether we are or IPD, may not be making enough eye contact. Nowadays, most of our EMR, because we are electronic medical records, forces us to look at the computer monitor. And if we are using case sheets, many times we are focusing on the case sheet. So make sure that whenever you are having an interaction with your patient or the family, make an eye contact, and then subsequently you can go and look into the monitor or the case sheet. But first and foremost, make an eye contact. Equally important is smile. I'll take a minute in this. We know that babies have something called as a social smile. It is not something that they are taught. It is something that nature provides. It is thought to be a survival reflex, because when you have a smiling baby, mostly adults will be protected towards it. So social smile in babies is not because they recognize who the adult is, It is some kind of a survival instinct. Similarly, for adults, you and me, we may be smiling in our day-to-day lives, but it is only with those whom we know, whom we like, not necessarily with everybody we are dealing with on a professional basis. Therefore, a professional smile is a skill that we need to practice. It does not come spontaneously. Just like babies have a social smile at a certain age, which protects their life, we have to learn a professional smile, which will protect us from time to time. Now we have to practice this. It doesn't come spontaneously. It is like any medical skill. Somebody teaches you, you practice it, and you get better at it. For example, when you were learning to take BP in the first year of your physiology lab, it was so difficult how to tie the cuff and all. Somebody taught you, then you practice. Now you can do it as a spinal reflex. You don't have to use your brain. Similarly, when you practice professional smile, eventually you practice, then it becomes second nature. You don't have to think. A smile comes into your face the moment you see anybody. And how do you practice it? When you go back to your hospital, you smile at the security person. If you don't do it on a regular basis, smile at the cleaning staff, smile at the catering staff, smile at the F&B staff, smile at the administrative staff, smile at your nurses, smile at your colleagues. Often we are so much engrossed in our work, we don't make a conscious effort, a cortical effort to practice this professional smile. But once you get it and you practice it, it will become like a spinal reflex. Anything resembling a human face passes in front of you, a smile will come onto your face. And if you practice this and get the professional smile, there is another advantage. The tone of your voice will become good. It is impossible to have a bad tone with a smiling face, because when you smile, automatically the tone of your voice will be warm and welcoming. If you have a grumpy face, the tone of your voice will be grumpy, unfortunately. So if you practice smiling, you will get a good tone of voice, free. Now, this is one slide I will again spend some time. There is this concept called body positioning. Your patient, irrespective of their financial or social status outside the medical world, they may be somebody of very high social standing, but the moment they come into the healthcare system, they become the seekers of your services and you are the providers. So there is a hierarchy of a lower position for the seeker and the higher position for the provider. And we in the healthcare system, whether we are doctors, nurses, ward boys, anybody, because we are in the healthcare system, hierarchy wise, we will be above the patient and family, irrespective of their financial or social standing outside the healthcare system. Forget about those who are unfortunate in the lower section of the pyramid, social pyramid. Therefore, to enhance satisfaction, if we position our body in alignment, so as we align our body position nearer to the eye level of the patient and family, the satisfaction increases. As the body position increases, then the satisfaction decreases. So here you have on the left upper part of the screen, you have a healthcare professional standing by the bedside of a patient. And here you have a healthcare professional on the right-hand side upper picture sitting by the bedside of a healthcare professional. So as I said before, here the eye level is above the patient. So there is a hierarchy of body position, lower, higher. Here the hierarchy is equal. So this will increase satisfaction. So when you go for rounds, pull up a chair. If somebody comes to meet you, offer them a chair. So when you bring your position equal to the patient or the family's position, it increases satisfaction. So this is something that we have to think about. Another thing that you have to consider is that, look, this healthcare professional is standing nearer to the head end of the patient, and the patient has to turn the head to make eye contact. This will be uncomfortable for the patient soon because the neck will start hurting. Whereas if you place yourself nearer to the foot end of the patient can make eye contact more comfortably. This will also be more satisfactory. So when you enter somebody's room, try to position yourself nearer to the foot end. I'm not saying stand here, I'm saying stand somewhere here, or sit, preferably sit somewhere here. This will enhance satisfaction. Once you need to examine the patient or do some procedure, by all means go nearer to the head end if you need to. But the beginning part, when you go in and say, hi, hello, how are you? Those kind of things, try to position yourself nearer to the foot end and try to sit down and while you're having a conversation. I'm not saying spend more time. Spend whatever time you spend, be it 2 minutes, 3 minutes, 5 minutes, whatever is the usual time you spend with your patient when you go for rounds, but sit down and spend that time instead of standing and spending the time. When it comes to children, at the lower picture shows, because children are smaller in size compared to adults, we adults have a tendency to bend at our hip to look down upon the child. We may not realize it, but again, it is creating that hierarchy. Often children get scared when we bend down at our hip and look at them from above. Instead of that, if you can bend at the knee, or a simple way would be to just pull up a chair or a stool and sit down and make yourself at eye level with the child. It will increase satisfaction. It will reduce the fear of the child of an unknown adult. So here, very important, make sure that your body positioning is aligned with the eye level of the patient. In simple words, sit down and talk. Another important area is body posture. If you are in Lardos's position, rest assured you are sending out very negative energy. The person who has come to see you will think of you as either arrogant or maybe not interested to talk. Whereas if you sit with a bit of a kyphosis, you are conveying the message with your spine in kyphosis. I am here to listen to you. I'm interested in what you have to say. So that is a very positive message and very satisfactory to the person who has come to meet you. So when you go to see a patient in the IP or when somebody comes to see you in the OP, the starting point, you make sure that you have adopted the slight kyphosis posture. If it is a long interview, sometimes, let's say when you're trying to communicate bad news or managing pollution, it may not be a 5-minute interview. It may extend to half an hour or even more. At that point of time, when you see the person sitting in front of you going back, then you also go back. When you see the person coming, leaning forward, you also lean forward. So it is basically like a dance. Both of you are sitting and having a conversation. The person in front of you leans back, you also lean back. The person is sitting in front of you, you leans forward, you also lean forward. Basically, you are mirroring the person. And it is also kind of copying the person's movement. In psychology, it is a well-known entity that when you copy somebody body language, you make yourself more likable. But the copying should be very discreet. It should not be evident. If it becomes evident, then the total opposite effect will come. That person may feel offended that you're trying to mock him or her. Whereas if you do it discreetly at the psychological level, you can make the other person like you. So it is very important that how you manage your body posture. So here are a few examples of leaning forward in our day-to-day encounters with our patient or the family. Another area that we need to understand is respecting the body space. We all have bubbles around us. There is an intimate space where we willingly allow only those with whom we are intimate. Those who are not intimate with us, for example, those whom we know socially, if they come and stand very close to us, even if we know them, it becomes a little uncomfortable, because with those whom we are socially engaged, they may be our colleagues or patients or some other people, we always maintain a little bit more distance than with those with whom we are intimate. Paradoxically, if those with whom we are intimate, they purposefully stand far away from us, we will feel uncomfortable. Often we will feel offended. We'll say, why are you standing so far? Come near me. So depending on what is our relationship, we tend to keep a little bit of distance or less distance. And those in public spaces is for people we don't know. We create some more distance. However, in certain situations, for us, for healthcare professionals, we have to get into the personal space, the intimate space of our patients because of the nature of our work. We have to examine them, we have to do some procedures, but you can say there is an implied consent. They came to us, and therefore, because we have to examine them, we have to touch them. Even though we are not intimate with each other, they are not our close friends or relatives. They are, people we hardly know. At best, we know them socially. Please understand that even if there is an implied consent, emotionally it is traumatic when somebody enters into your intimate space, somebody who is not intimate with you. It is an emotional thing, but we have to work. We have to auscultate. We have to palpate. We have to percuss. We have to check BP. We have to put in a cannula. We may have to do all kinds of intrusive activities. And all of this can make a person uncomfortable. And this discomfort can be dissatisfying. Therefore, to reduce the emotional discomfort, we have to tell them what we are going to do before you actually do. For example, if I have to auscultate a person sitting in front of me, I'll take my step and put it in my ear and I'll show the chest piece and ask, may I? Or I'll just shake, in Kerala, we have this famous head shaking, diagonal side to side. So that is asking permission. You don't have to say, you can even do it by body language. So basically, if you are going to touch the patient, let the patient know you are going to touch. You don't have to take an elaborate permission. You just say that you're going to do it. Another thing, if you're going to do a procedure, before you do it, tell what the procedure is about. A very short summary of what this is about. And while you are doing it, do a running commentary. Now I'm going to wipe this area with betadine. It will be a little wet. And now it is over. I'm going to put a towel over you. Now I'm going to give you a local anesthetic with a small needle. I've given the local anesthetic. I'm going to wait for 30 seconds. So step by step, you do a running commentary, just like our cricket commentators do a running commentary, and we enjoy the visual as well as the auditory stimulation of the cricket match. Similarly, when you are giving a running commentary of what you're doing, the patient is reassured. at every point of time, they know what is going to happen next. There is no confusion. There is no suspended animation. There is no anxiety related to what is going to happen now, because you are continuously giving a running commentary. All of this will enhance the satisfaction of the patient. So here are two examples of how barging into somebody's personal space. You can see the body language of this patient who is trying to lean back as much as possible into the chair, because how this body language, it seems to be little aggressive. Whereas see this picture on the right. This is, by the way, my palliative nurse on a home visit to one of my patients. And see everything that we talked about right now: eye contact, smile on the face, right? And of course, we can't know the tone of the voice, but I assume it will be nice. And then you have the body position. Both people are sitting, so eye level. Yep. Eye contact is at eye level. No hierarchy between these two. And look at the body posture, a slight tilt of the head, a slight kyphosis here, and a slight kyphosis here also. And look at the distance, comfortable distance between these two. So overall, this is a very nice picture, and this is what we should be targeting at. And last but not the least, don't forget to touch your patients. So of course, we are in this COVID scare. In the whole of 2020, I just didn't touch any of my patients because I was so scared. But then by 2021, we realized how we can deal with COVID, mask ourselves, sanitize, and started retouching our patients. What does touch means? We're not talking about touch as part of procedure, as auscultation, palpation, or putting an ICD. No, we're talking about how we will touch a human being, a human touch as part of a regular interaction. So when I go for IP and I just give my hand as a handshake. And when you give that, you'll see people will grab onto it with both their hands. They're so grateful for a doctor giving them a handshake. Same thing you can do in the OP, or just a touch on the shoulder. Remember, no patting. Patting is paternalistic. You cannot pat your head of department or the principal of your institution or the mantri. You can't say, oh, you've done a great job. You can't pat. So what you can't do up, don't do down. So therefore, please understand, patting is a part of a hierarchical body language. Don't do it, because you can't do it to somebody in a higher position than you. So you do only for somebody who is in a lower position than you. So instead of patting, just touch the person for an optimum time and then take your hands off. So shoulder is a good area to touch. The back of the hand is a good area to touch. Outer part of the arm, the forearm, all these areas are gender neutral. You can touch. The best way of touching is a handshake. Now coming to some verbal do's and don'ts. Many a times when we ask questions, without us realizing it, we may be asking a leading question. A leading question is basically a psychological thing that we want to hear, preferably a good news. And the questioning is in a way which kind of guides the patient to give us an answer that we want to hear. Your breathlessness is better now, isn't it? So when you ask a question like that with a tone like that, it will be very difficult for your patient to say, no, your medicine did not help me at all. An empowered patient may say that, but how many empowered patients do we usually have? So most of the time they are usually scared of us. So when we ask a question, your breathlessness is better now, isn't it? So they may not be able to say, no, it's really not better. So if you want to get the right kind of information, ask an open-ended question. How are you today? And they will tell you not only about your breathlessness, they will also tell that they could not sleep because of so much of sound in the next room. They'll also tell, I have money issues. So if you, it depends on how comfortable you make them, that they can say whatever they have to say. All their problems, they will be able to share with you if you open yourself up. And one way of opening yourself up, apart from all the body language, positive body language, is also to ask open-ended questions instead of leading questions. Do not minimize anybody's problem. If I have a toothache and you are the person who deals with cancer pain and things like that, and you say, oh, this is nothing, it's a small thing, why are you making a song and dance of it? I will not be happy with your uh, your attitude towards me. I'll not be satisfied. I'll, if possible, I'll go and get a consultation from somebody else who is more empathetic. So don't minimize my problem. For me, my problem is the biggest problem in the world. And I have a toothache, and telling me, oh, this is, such a small problem. Look at, you go to the cancer pediatric ward of the cancer center. There you will see what real suffering is. When I have a toothache and I'm suffering from it, I don't care. Children are, suffering from cancer in some cancer center. For me, my problem is the only problem. My problem is the biggest problem in the world. So do not minimize my problem. Do not compare my problem with somebody else having a bigger problem than me, according to you. Instead of that, acknowledge that I have a problem. Who is it? This must be so terrible. And normalize my emotional experience. I may be making a song and dance, I may be, doing all kinds of things. And if you say, anybody in your position would perhaps, be doing this, I'll be happy. I will realize, I'll say to myself, at last, here is a doctor who understands my suffering. So basically acknowledging patients' suffering and normalizing their emotional experience, not normalizing their problem, normalizing their emotional experience of the problem will increase satisfaction. There is always scope for giving hope, but never give false hope. Always give realistic hope. On a day-to-day basis, even today, a patient come to me referred from various people, oncologists, pulmonologists, gastroenterologists, all kinds of referrals come. But usually what is uniform is that they have had an incurable, progressive, advanced medical condition, nothing much else from the disease specialist, and the patient has been referred for supportive care. And it's usual for me often, of course, there is, on the merit of the patient's case, what I say, how I say may differ, but by and large, when I tell them the disease is incurable and it's progressed to an advanced stage, no further disease treatment would be possible. However, I'll make sure that you will not suffer. I cannot treat your disease, but the problem that you have, the breathlessness that you have, or the pain that you have, that I can take care of. And that can be taken care of for as long as you want. Now, that is something I can realistically do for you. And that confidence that I have within me comes from my training in palliative medicine. That there is no situation called as a hopeless situation. There may be limits to cure, but there is no limits to care. We can provide comfort to patients with an incurable, progressive, advanced medical condition for as long as they want. It is not that you start some medication in the beginning and at the later stage it will not work. There is nothing like that. You can provide pain relief or breathlessness relief for as long as the patient needs. Now, this is something that I give without saying. I'm also giving a message that I will never abandon you. So this, when I give this messaging, verbal, non-verbal, all combined together, the usual response I get back is, doctor, that is all that I ever wanted to hear. Or if it's a family member, they say, doctor, that is all that we ever wanted to hear. and variations to that theme. So remember, hope is very important. Never send somebody off your OP or never walk out of your IP without giving hope. But make sure you give realistic hope. Never give false hope. One very, very important message that I want to convey is do not assume. The danger is when you assume and you don't even realize it. If you assume and you know you're assuming and you say, I assume this must be the case, that's a different matter. But the danger is when you assume without you even knowing it. So look at this situation. You give medications to your patient and you go for rounds and you say, how are you today? How's your breathlessness? And the patient says, much better. And that usually is the end of the story. But how about asking, did you have satisfactory relief? Not really, but I'm much better. So basically, when you say, how are you today? How is your breathlessness? And the patient says, I'm much better, or now it has reduced a lot. And then you ask, do you have satisfactory relief? And if the patient pauses and thinks, not really. So that is something that you will have to ask instead of assuming that everything is fine. When you ask, you will know. It's as simple as that. So coming and combining everything together, we all know how to take a history, but this is history taking 2.0, including all the things that we learned today. That is body language, positive body language, as well as some verbal do's and don'ts. In short, how to take a history using active listening skills. The moment you are having an interaction, the moment it starts, you start with a greeting. Greeting involves making an eye contact, a smile on your face. Remember the professional smile? Nod of your head, and what is culturally appropriate in your area. It may be hello, good morning, namaste, namaskar, whatever is culture appropriate. If nothing, then at least an eye contact and a smile and a nod of your head should be there. Next important thing is get comfortable. If people have come to your OP, offer them a chair. In my OP, I try to give a few spare plastic chairs which I can stack one on top of the other so that it does not take space. So in case there are more people, then I can always accommodate more. Usually there is two chair for a family and one chair for the patient. So 3 chairs, but always you can keep more. Start the interview with an open-ended question. How may I help you? What brings you here? And if you have gone to the IP, you can ask the patient, how are you today? So all of these things will be a good way of starting the interview. And then listen. Lot of studies, lot of research has gone into this area, and they have found, unfortunately, that we doctors interrupt our patients within 15 seconds of them starting to speak. The moment the patients open their mouth, we interrupt. Median is around 8 to 9 minutes. So not only we have to listen and hear what they have to say, we also need to encourage them to talk. And how do you encourage them? Maintain eye contact. Remember eye contact. Nod your head from time to time, and also make encouraging sounds like okay, go on. So when you do all of that, the patient will be encouraged to talk and clarify as you go along. I did not understand. Can you just repeat what you just said? Or you say, this is what I understand. Am I understanding it correctly? So it's very important that you do not assume something. You ask, clarify, and go on. Because it is very easy to fall into the assuming trap. Once you understand this problem, because it is human tendency to assume. So once you teach all your team members communication skills, then you can make a game of assuming. Everybody looks out if somebody is assuming and then ask, is that an assumption? So when you make it as a game, people will gradually learn to overcome this problem of assuming. It's a skill that does not come easy. Just like professional smile, you have to practice it. Very important, ask them what do they know. Many a times they may have no clue as to what is happening to them, or they may understand a few things correctly and they may understand a few things totally off the mark. They may have a totally wrong understanding of the situation. And often it's a mixture of all of it. I have asked people, what was the name of the doctor you consulted before? They have no idea. I asked them, what kind of doctor was it? I mean, what specialty? They have no idea. Each one of you, please market yourself. Who else will do it for you? You have to take that effort. Tell your patient and family what your name is. Tell your patient and family what you do when you go for IP consultations or in whatever situation. Just because your name, big board is there with your name and many, many degrees, it is not necessary people understand who you are and what you do. Market yourself. It will be in your best interest. Also ask about their concerns. Now, this is very important because as healthcare professionals, all of our training is focused. Our concern is pathology. Our concern is differential diagnosis. Our concern is treatment modalities. And we go to great lengths to take care of our concerns. We do extensive investigation, extensive, consultations with our colleagues, medical board, tumor board, all of it. We take a lot of effort for our concerns. But what about their concerns? What are they worried about? What are their concerns? Is finances their concern? Is logistics their concern? They have a problem that they don't have a bystander to come and stay. What are their beliefs? All of those things are very, very important. So find out what their concerns are. What are they afraid of? And once it is time to share information, share it honestly. And while you share it, use simple language. Instead of saying, let's say, the USG shows a cyst in the ovary, don't worry, everything is all right. For each one of us, we understand that what I just said. But imagine from the patient's point of view, they went and paid money for a scan of the stomach. And here the doctor said the USG. So from the patient's point of view, we paid for scan of stomach. They did a wrong test called USG. And then they are saying there's a cyst in the ovary. Ovaries, we understand, but cyst means cancer. And the doctor is saying everything is fine. There is something wrong. They are trying to cheat us. So in simple word, if you could say the scan report of the tummy has come out and it shows a small swelling in the ovary. And from the looks of it, it seems that it is harmless. Simple language, no jargon. And when you are discussing treatment options, remember, compliance will happen only if the patient and family understand why we are suggesting whatever we are suggesting. We may have had a big medical board or a tumor board, and we may be giving them the best treatment option. But if they don't understand why we are telling them, it's the onus is on us to make sure that we convey why we are suggesting whatever we are suggesting. But that is not enough. They may have their beliefs, they may have their fears. They may have some traditional understanding of the situation, which from our point of view seems rather stupid. But from their point of view, that is their reality. They absolutely believe in it. Or maybe they just don't have enough money for the treatment that we are suggesting. So maybe just like we do a medical board or a tumor board, where we talk to various of our colleagues who bring onto the table various specialities, maybe we should also sit with the patient and family, because the patient and family specialty is, it is their life. They know their life and whatever is in their life better than any of us. So when we sit with them and we negotiate, it's not the high and mighty, we say my way or the highway. We tell them, this is what our suggestion is. What do you think of it? And then they may have a few questions, they may have few concerns. And many a times, remember, it's not often the best treatment that succeeds. It is the most practical treatment that succeeds. And how do you make it practical? When you sit with the patient and family and discuss. So you tell your part, they tell their part. We move a few steps on one direction, they take a few steps, and together we come to the meeting point. And what is practical gets done. The optimum or the best treatment may not get done. And what do we want? We want to get things done. And that is why it is important to learn communication skills, because it gets things done. Not only that, it reduces your time, energy, and effort in getting things done. That is why we learn it for our own selfish interest. So this is called participatory decision making, where we discuss with the patient and family and come to a conclusion. So if it is a long interview, we summarize. If it's a short interview, no need for that. About what we talked, we confirm what's the treatment plan. And before closing the interview, after all the discussion, especially with complicated medical conditions, sometimes the interview may be long. We always ask in the end, is there anything else that you have in mind? Is there anything else that you want to say? So this is, if I may want to compare with, if you had a sumptuous meal, in the end, you take a sweet dessert and you feel complete. So this question, last thing, is there anything else? It usually brings a smile onto the face of the patient and family. And it is with this smile that they should go out of your OP. It is with this smile that you should walk out of the patient's room in IP. It is the whatever interview you have had, in the end, it should end with a positive, at a positive note. And also, let's say you have asked them to come after 2 weeks from your OP, always tell them that in between you need, if you need, you can come in between. Why I say that? Because often when I do home care, and I see patients who are under the treatment of some other doctor, and the doctor has given a discharged patient a review after 1 month, and the patient is presently having a lot of disease-related problems. And then I ask, why don't you go back to the hospital and why don't you go back to your doctor? And they say, but they are asked us to come after 1 month. It's only 2 weeks now. We have to wait for another 2 weeks. Now, I'm sure that you will be thinking, I mean, that is common sense. They should always go back whenever they have a problem. But the issue is that what seems like common sense to us often is not the case with our patient and family. Many of them think that they are not supposed to go and meet their doctors. They have to supposed to go and meet only as advised by the doctor. So when you tell them that you can come in between, it is leaving the door open for them whenever they want to come back. Also give them a number through which they can access your services. If you don't want to give your personal mobile number, don't give. But give them some contact number, your department number, hospital emergency contact number, or your social workers, anybody. So give them some contact number. And in the end, just like how you started, you just complete the circle. In the end, there is a greeting. You make eye contact, you smile, nod your head, and say what is culturally appropriate. in your area. So that is how we finish the history taking incorporating active listening skills. Remember, active listening skill is a very, very dynamic process, which you might have realized by now. And all of this, all the positive body language, all the care in how you formulate the sentences in your verbal part of the communication, all of this is showing empathy. We are showing we care. No matter how many degrees you have, no matter what kind of a five-star hospital you work in, no matter how many crores of machine you have in your hospital, no matter what kind of facilities you have providing for them, they remember how you made them feel. And often that is the only thing they remember. Therefore, practice positive body language and remember the verbal do's and don'ts. With this, I have come to the end of the session. I will be happy to take some questions. Sridevi, should I stop sharing?
Yes, sir. Yes, please.
There you go. Thank you.
Thank you so much, sir, for the introduction to communication. We'll take up a few questions before the discussion. Either you can unmute or you can type in the chat.
Or in
Yes, sir.
any questions in the chat box, Sridevi,
Yes.
if you could help out with
Yes,
that.
sir. So can you hear me?
Yes, I can.
So there is a question. Does our white coat put off the patient?
Oh, yes. I mean, any sign of authority would scare anybody. Before joining MBBS, that white coat was of aspirational value. When I joined MBBS, I wanted to wave this white coat to the entire world to see, hey, I have got it. I'm sure most of you would have at least had an experience of wearing the white coat and going to a public space and strutting around because you have, finally, achieved it. After some time, the novelty wears off. But remember, why it is so enticing? Why is the white coat so enticing? Because it's a sign of power. So is the step around her neck. So is the name badge, name tag, and everything that goes in the jing bang that goes into proclaiming, I am a doctor, I am somebody of authority. And all of this can scare our patients and families. Like, we may not realize it, but we have horns. And the more senior you get, the HOD, the professor has the biggest horn. The assistant professor has a comparatively smaller and smaller. But we all have small, small horns. And we can't see it in our mirror, but the patient and family can see it. And there is a fine line between scaring people and inspiring confidence. It's a very, very fine line. So, of course, we have to wear our white coat. Of course, we have to wear our steth and all of that. But how we use our body language, a stern face, can scare anybody with the coat or without the coat. So, coat, steth, name badge, all of these are inanimate objects. What they do to you when you wear all of that, and your facial expression changes, the tone of your voice changes, the smile vanishes, all of these things create an image that we ourselves may not realize, but the patients can see, the family can see. So wear the coat, wear the steps, have a smile on your face, have a nice warm welcoming tone in your voice. Even with the mask on your face, your smile can be seen in your eyes, and your smile can be heard in your voice. And make yourself less scary.
Sir, there are a few more questions in the chat. How do we deal with defensive patients and those who seek second opinion due to mistrust in their previous physician?
I'll come to the second part first.
Yeah.
Why should anybody trust you? What have you done to earn that trust? Right? You have to earn it. It doesn't come easy. Just because you're a doctor, you have a name doctor in front of your name and 1 mile long degree behind your name does not guarantee you trust. When you write a prescription, they will take this prescription to the medical shop and they will ask the person dispensing the medicine, should I take it or not? And the person who is dispensing the medicine may be a 10th class fail. The only qualification that the person has, because the person knows where every medicine is kept. That person may not even be the pharmacist. The pharmacist, whatever degree which is used for the license of medical shop, that person may be somewhere else. And they will believe this person, oh, this is a hot medicine, this is a cold medicine, yeah, I will give something else, and that doctor doesn't know anything, and they will believe that, right? So why? Because we are not accessible. Why do you think the Ayush doctor, the Ayurveda, homeo people score above us? We are all scientific and all, but we speak mumbo jumbo. They don't understand our language. That is why we don't earn that trust. You don't speak the language. How can you, will you trust somebody who speaks Chinese? Unlikely. Because first of all, you do not understand what the person is saying. Does he want to kill you or want to, feed you? You will not know. For example, this bone that we have in our, this area, Sridevi, what will you call this? This bone over
Not in
here?
English, sir, some other language.
Yeah.
Clavicle, sir.
Clavicle. What language is that? Is that English? Is that Hindi? It is Telugu, Tamil, Malayalam? No. Clavicle comes from the Greek word clavus, which means like a key, and that became clavicle in Latin. And that is what is taught to you and me from the first day we put our leg inside the medical colleges. All our medical education is in Greek and Latin. And that's the only language we know once we come out of medical colleges as doctors. Before we went in, we were speaking normal human language. And after that, we are speaking Greek and Latin. And you speak Greek and Latin in front of your patient and family. They shake their head. And after that, they have no idea what we said, because whatever we said sounds like Greek and Latin to them. How are they going to trust you? First of all, speak their language. Appear human being. Did you smile at them? Did you touch them? Why do you think they should trust you? What did you do to earn that trust? If you earn that trust, they will stick with you. Of course, they will go and take second opinion, third opinion, fourth opinion. But if they trust you, they will come back to you after the sixth opinion. And don't you think that they have the right to have a second opinion and a third opinion? Wouldn't you go seek a second opinion and a third opinion? If that is kosher for you, why is not good enough for the patient and family? I hope that answers your question, Sridevi.
Sir, so connected to that, again, you're talking about the language that we speak, the jargons that we use. So another question is there, like we explain the problem and the options available, and finally the bystander asks you that, so there is not much of a problem, right? So how do you deal with it? Do you think it's connected?
It's a very, very common thing. Please understand, there are multiple aspects to it. One, we don't know what is the psychological status of the person who asked that. The person may be terrified. And it's just like we sometimes hug ourselves, like holding hands like that for some reassurance. It may be a cry for reassurance. Don't assume why the person said that. Ask, why did you say that? Try to figure it out. It may be that the person knows something but is in denial. We don't know. So it is very important. I understand it's a very common thing, but we have to deal with it on the merit of the case. For every individual, we will try to figure out what is the reason which made them say that. Simple. Why did you say that? Why did you ask that? What are your concerns? What are you worried about? You know. So when you hear somebody say everything, in it's coming in Malayalam, but I know it's a mixed audience. Let's say in Hindi, और तो कोई problem नहीं है ना. So that kind of a response when that comes, we are from what was I telling you for half an hour, and now you are saying now there is no other problem, right? So this happens, but we have to be patient. We have to understand that people are scared, they are worried. See, nobody comes to us because they want to come to us, right? We are not giving them any entertainment, right? And hospital is not a movie theater or a restaurant. Nobody comes to us because they want to come to. They come because they are sick, they are suffering. So it's all the negative things which makes them come to us. So then they are desperately looking for reassurances. So sometimes we may have to continue the messaging once, twice, thrice. Hey, we all remember in our exams, first time you read the Krebs cycle, it did not make sense to me. I tried maybe 10 times, still it doesn't make sense to me. So basically, revision, continuing the messaging, take patience, continue the messaging, and hopefully they will understand. There are many ways to deal with it. But I guess some of the things that I said should help.
Sir, so this is next question is, I think, the most common question that I ask you from the chat. Multiple bystanders.
Right. So two people come, you spend half an hour, you explain everything. Then next day, two new people come. Is that the way the question was?
Yes, exactly.
Good. That's a good question. I really, thank the person who put in that chat. We spend a lot of time dealing with this, and we get frustrated. So my usual pattern pre-COVID, post-COVID, now there is a difference. So pre-COVID, whenever, and this is usually a case when we are dealing with something very complicated, patient in the ICU, we don't know whether the person will make out or not, and things like that. So when we are dealing with complex situations, remember, we are all busy people, we don't have time to waste, we definitely don't have energy to waste. So my usual pattern is, I tell whoever is the bystander, I tell, I have something important to discuss with the family, call everybody. And tomorrow at so and so time, I will be there. And bring everybody who is has a stake in this person. Who all are the decision makers? Everybody. Now, this approach is very different from our conventional approach, because in our conventional approach, we may have two bystanders coming into our OP to discuss something about the IP patient, because there is usually a person standing guard outside our OP, a staff, who lets in only one or two people. And we are also comfortable dealing with one or two people at a time. Problem with that is, when we talk to the two people, we may have ignored somebody else in the family who may be hierarchically in a higher position. And if that person feels slighted that we ignore that person, then that person will come and create trouble for you at every point. So we have to have the discussion with people all together. So as I said, in my room, I always keep plastic chairs stacked up. So in case there are more people, I've had occasions where I have had a family counseling session done with 15 people in my room, which not only involved the patient's relatives, but also a neighbor who was a lawyer and was the most close confidant of the family. Now, when I have everybody together, then whatever I have to say, everybody listens at the same time. And whatever somebody else has to ask or say, everybody else listens at the same time. They get to hear it at the same time. The usual pattern that I follow is this. I ask them, what do you understand about the medical condition? So there may be one person who understands everything, that person may say everything. This may be new information to some other people, but because that has come out in the open, now everybody gets to hear it at the same time. Everybody is on the same page as far as the information is concerned. Next thing that I ask, what are your concerns? What do you want? So we understand what they know, and then we ask, what do you want? So they say whatever they have to say. Then I will share information. What is the realistic situation and what can be done and what cannot be done. Of course, it is done in a very sensitive manner using all the active listening skills that I just mentioned about. So this way, everybody gets to know what is the patient's condition, what is it that the family were looking for, from the medical point of view, what is realistically possible, what is not possible. And many a times, this discussion, sometimes there may be some difficulty in making a decision, and I usually have to sit back because they themselves discuss and come to a conclusion of how to go forward. Basically, I am delegating responsibility. I'm taking away a lot of my responsibility and distributing among all those people situated. It works good for me because whatever decision we have taken, the patient in the ICU, should we take the ventilator off? Should we continue? All of this decision we take together. So it is not just, oh, doctor said that. So it is not just me who is going to get crucified if things go wrong. It is everybody taking the decision together. And that one session that I spend, it may take half an hour to 45 minutes, but overall, I save a lot of time, energy, and effort. So that is the physical offline meeting family counseling session that I used to do. Post COVID, now thankfully in our hospital we have a telemedicine, so we are able to connect online with our patients' families from across the world. Even otherwise, we have WhatsApp chat. I had occasions where I have made a chat group of a patient family, whoever wanted to be in. And sometimes it's a hybrid, one or two family members are in my OP and some people are online, and together we manage. So basically, pre-COVID, post-COVID, the modalities have changed, but the standard operating procedure remains the same. I just don't have time to waste or energy to waste. So this works just fine. Only thing is, we as medical professionals are not very used to dealing with a large group of family. But hey, your OP, your hospital, you should be the king of that place. You know, why should you be uncomfortable? You know, you should be in charge.
Sir, maybe one quick question before the case presentation. I know that we overshot time for the case
We have.
presentation. Yeah. So, but I think it's relevant. So when you've done an extensive procedure and a lot of workup to arrive at a difficult diagnosis, and then the patient and the bystander were hiding something like a retroviral infection. How would you deal with it? Like real life experience, would you get angry or smile?
Difficult, right? How can you smile when you know that you have been stabbed in the back? And where would getting angry take you? You get angry, you have a scene with the family, now your relationship is broken, friction has come in, god forbid something happens to the patient, then you are going to be at the other end of the stick. It is on our selfish interest to maintain cordial relationship with the patient and family, period. We will face often frustrating, irritating experiences in our life, unfair experiences in our life. Hey, but we all chose to become doctors, right?
Thank you, sir. I don't know, Dr. Kiran, whether you are You got it.
Can
I'm
I,
not-
Sridevi,
I'm
with
not-
your permission, can I ask Dr. Biju?
Yes, ma'am.
Is,
Yes, ma'am. Yes,
no,
ma'am.
Dr. Biju, is it okay to tell the patient's family that you're disappointed and that you didn't expect this from them? Is it not right? Because I think that's the first thing that I would say, that I really didn't expect you to withhold this information from me. I'm really disappointed. And I think it's important you realize that you are also potentially put somebody at risk. It's important for them to know so that they don't do it to another doctor or another colleague.
True. I agree with you on the principle
And
of
very
it.
emotionally, I mean, not aggressively.
Yeah.
I mean, you need to be assertive. You can't do this. You can't take this for granted. One, please don't do this to any other doctor. I really didn't think that you would be doing this. I'm really disappointed in you.
Yeah, I would say that, but maybe I would tone down the tone a little bit while I'm doing it.
Understood. So it's the same thing about the COVID, right? You see people so blasé about, even in the peak of COVID, walking around without mask, partying, and here you are going to work every day at 9, not knowing whether you're going to come back with COVID. You see that irresponsibility that the general public had. It was irritating. It was very upsetting. And we know how all of us went to work and what stress we had, and how about our family, children, elders, etc. So it's the same kind of response, the sense of responsibility that people lack. And how do you instill that? I mean, yes, doctors have a lot of scope for improvement, but the common man also needs to take its share of responsibility. So how do you communicate that? Even in a pandemic, people were irresponsible and misbehaved.
Thank you, ma'am, for that. As far as this is concerned, I would often see people inside the hospital not wearing a mask. I mean, imagine inside the hospital. So I would, I'll go and talk to them. Where is your mask? And oh yeah, I have it. Then they will put. So maybe you don't have to use a danda, but you can use another way of doing it. I'm more of a pacifist. I don't like to ruffle feathers, and I know that ruffling feathers might work to my disadvantage. So yes, as a society, we need to be more civil. We need to be more disciplined. But then we will not be living in India, right? We are quite a chaotic nation, and that reflects in our individual behavior. We can always tell people that this is how the government is every day telling people what is the right thing to do, but then people don't say. And this brings to another thing, because as Rajam ma'am said, that this we might get frustrated seeing so much of anarchy around us. So it's very important to make sure that we take good care of our mental well-being. There is more to life than being a doctor. If you're 24 hours you are a doctor, then you don't have a life. Other people have life, remember that. So once you become debilitated, then you don't stay in the bed and wishing, oh, if I could have done something better with my life. Take care of your well-being. Have a hobby, have a pet, sing a song, meditate, or do whatever, but please take care of your mental health. Is grossly ignored. We healthcare professionals. We die. Nothing will change. It will. Your family may cry for a few days, but your patient and their family, they will move on. Somebody else will come and sit in the same chair. So have a life. Don't take everything so seriously. Uh, have some fun. Have a laugh.
Thank you, sir. Sorry to stop there. We'll move on to the case discussion. Dr. Atul.
My slides are visible now.
Yes, please go ahead.
Good evening to one and all present here. Myself, Dr. Adul, and doing my post-graduation in pulmonary medicine in Chhattisgarh. So I have a case or patient with a 60-year-old male with a diagnosis of an acute exacerbation of COPD, that is grade 4, and group D, that is advanced disease with respiratory failure and hypertension. And the presenting complaints The patient came with breathing difficulty for the last 3 days and cough with expectoration for the last 4 to 5 days. History of illness and the patient having similar symptoms for the last 10 years, and that is aggravated recently in the last few days. That is breathing difficulty that is increased last 3 days, which was grading from MMRC grade 3 to grade 4 and increased especially during the night time, and that is relieved by taking nebulization and in the sitting posture. Also, patient had uh, cough, which is progressive and associated with expectoration, and that also increased during the night time and somewhat relieved by taking the medication. On examination, on admission, patient was conscious, irritable, tachypneic, and the saturation was 70% at room air, and the BP was 150 by 80, and pulse rate was 150 beats per minute, and patient was febrile and having using accessory muscle for the respiration. And the respiratory system examination, there was a bilateral diffuse rhonchi was present, and we have started treatment with oxygen inhalation with using venturi mask and nebulization with the bronchodilators. And he also received intravenous corticosteroids and IV antibiotics. Later, we forced to shift the patient from venturi mask to the non-invasive ventilatory support. And the previous CT thorax of the patient have suggested that the severe emphysematous changes, and the current ABG shows the type 2 respiratory failure with elevated inflammatory markers, and the 2D echo was having a mild LV dysfunction. And the chest X-ray also show the hyperinflation. The in the particular patient, the psychological aspects of the patient and his wife is living in a remote area in a village, and the children and relatives are less concerned about the patient, and the difficulty patient had a difficulty to reach the hospital for his regular medical checkup and further treatments, and he himself feels that he become a burden for the entire family because of this progressive disease and recurrent admission in the hospital, and he himself having a limited normal activities due to the illness. And he was on medication like long-acting and bronchodilators, Neriflins, and calcium. And somehow he used to get intermittent oxygen supports in the home and antihypertensive and other nebulization medicine. And the main concern is the patient feels that if the his symptoms will be with him till his death, or are these drugs cannot save me or give symptom free life. The patient having taking this medicine for years, so irrespective of that regular medication, he didn't get any relief, symptom free relief time, and he is worried about could I get good time to spend with his grandchildren, and he is so much worried that the same disease will affect his children's also in their later life, and he actually don't want to see his family members getting affected badly because of his disease. And main concern, another concern is the financial problem for the further advanced management of the particular disease. So in the summary, a 60-year-old male diagnosed as a advanced COPD before 15 years and having the severe breathing difficulty even with the oxygen support and with the maximum medical treatment. For the last 2 years, the plenty of time he got admission to the hospital for the same complaint and had a long stay in the hospital. Many times he got large dose of steroids and non-invasive ventilator supports. In the recent 2 month, 1 month, he got admitted more than 2 times. And in the final admission, which was so prolonged stay and without any clinical improvement, with the maximum medical supports, and finally he got invasive ventilator support and in the stage that cannot be extubated from the ventilator and succumbed to his illness. And the discussion points in this case is whether any palliative care intervention can give him a symptomless period in his life, or in the side of a chest physician when and how we can refer a patient this kind of to a palliative management. And in case of the communication skill, uh, usually this type of any patients we are communicating directly with the patient relatives. in some most of the cases we didn't directly contact or we didn't talk the disease severity and the progression with this patient directly. That is, if I have a question that we had to tell about the real progression or the real disease to the directly to the patient. And another concern is that uh, in our experience, my experience, that if we have a good communication or rapport with the patient, it will uh, it will affect that it will have a good advantages in this further treatment or any complication, if any complication occurs. Or another question is when to start a end of life care counseling for or communication with the family or relatives for this kind of patients.
Thank you, Dr. Atul. Any response from the other participants? And thank you for the wonderful presentation. Any response from the other participants? When ideally should have this conversation, or how will you tell? Like his question was on referral to palliative care. So how will you actually talk about it? Referral to palliative care.
Devi, can we have that, what do you call, can we unshare?
Yes.
And so that,
Atul?
yeah.
Oh.
So there's a comment from Dr. Dheeraj, is it is not end of life, it's sustainability of life, and palliative care when the patient came first. There was a question on when it should have been communicated. I'm sorry, because of lack of time, while the chat's coming up, I think I'm just asking Dr. Biju just to share his thoughts about it.
Well, I tell this whichever platform I get. Palliative care and end of life care are two different things, but both have similar in the sense that we are trying to provide comfort from any suffering, physical, emotional, social, existential. Specifically, when we are dealing with breathlessness, yeah, there are plenty of things to do, pharmacological and non-pharmacological, to relieve somebody's breathlessness, even if the disease is incurable, progressive, and advanced. So when you provide comfort for a patient who has a curable medical condition, you are providing supportive care. When you are providing comfort to a patient who has an incurable chronic medical condition, you're still providing supportive care. So respiratory supportive care or supportive pulmonology, whichever way you want to call it. And when the disease, you as the pulmonologist, you know better when continuing the disease focused intervention is no longer evidence based. That is, whatever intervention you are doing, there has to be an expected clinical outcome, and that is what the evidence base is all about. If it does not feel like it is any more appropriate, there is, then the person is terminally ill, because you as pulmonologists know how to cure a lot of respiratory medical condition. You know how to control chronic respiratory medical conditions, but all of at a certain point of time, when none of whatever you are doing seems to improve the quality of life of your patient, then the patient is terminally ill. And then continuing what you are doing, maybe some of it can be continued if appropriate, but definitely putting that person on a ventilator in an ICU, providing critical care to a terminally ill patient is definitely inappropriate. When somebody is critically ill, that person has a good chance of dying. But when you provide critical care, there's a good chance of you getting that person back to normal life. That involves a fair bit of physical torture. Most of you might have experienced the discomfort of the COVID testing, that small thing going into your nose, and how it makes your eyes water with the discomfort. And imagine, allow getting the full ET tube shoved down your throat. I'll be surprised if anybody had had an experience in this group. I certainly don't have, but I imagine if such a small thin thing going into my nose can be such a trauma, what would be a thick ET tube going into my throat would feel like. So when you subject somebody to a lot of third degree physical torture as critical care, you can justify it because you're trying to save a life. But when you have somebody whose life you cannot save, evidence-based medical evaluation tells you that person is terminally ill, then how do you justify torturing that person? How do you justify keeping that patient and family alive, separate? How do you justify keeping the patient and family separate? Patient in the ICU, family outside. How do you justify putting the family through that emotional trauma? How do you justify the financial burden you put on the family? And many a times, because you have not conveyed the bad news 1 year ago, they may go around looking for cure that does not exist. They sell the cow, they sell the jewelry, they take loan, they sell everything in the house. Finally the house is gone and the family is on the road, and the patient eventually dies on a ventilator. How do you justify any of that? How do you justify the poverty that medical interventions create in this country? Lot of things to think about. So therefore, we have to have a clarity on whether the patient you are dealing with is critically ill or terminally ill. If the person is terminally ill, then prevent the patient from receiving inappropriate medical intervention and give what is appropriate. And that would be end of life care, basically comfort care that you design for a terminally ill person. End of life care is not given for somebody who's gasping. End of life care is given for somebody who is deemed to be terminally ill. This, what Dr. Atul, that excellent case that Dr. Atul presented, this person, from what I heard from this story, was terminally ill for at least for a couple of months now. Right? So terminally does not mean the patient is dying. Somebody can be terminally ill for months or years. Basically, that differentiation we should be able to make. And once you have deemed somebody terminally ill, we can do a lot of things for that person to have good quality of life. And in oncology, studies in stage 4 lung cancer, they have shown that when you provide good quality palliative care along with standard cancer treatment, people live on an average 3 months more. So good end of life care or good palliative care increases quantity of life by improving quality of life. So there's a heck lot of things to be done.
With your permission, Dr. Biju, I just want to add one
Please.
thing that is only because of my experience and the fact that I think I shared it with you all on the first talk, that I was only a pulmonologist 5 years ago, and palliative care has really made me a better human being and a slightly more empathetic doctor. There is a long way to go. I can't say that obviously I'm 100% there, but what I'm trying to tell you is, in a patient of COPD, you have seen 100 more COPDs. You all know the trajectory of the illness. You know that when a patient is on oxygen when you see the CT scan, how bad the lungs looked and what the prognosis could be. That's why these two documents that Sridevi will share with you gives you the right time to start the integration of palliative care discussions with your patients of COPD as well as interstitial lung disease. The two documents are the Blue Maple document and the gold standard framework, which gives indication: age above 75, multiple ITU admissions, or a drop in lung function requiring ITU admission, those patients who are got multiple comorbidities, the outcome of aggressive treatment where they will be poor. So there are clear-cut indications in each chronic conditions, also in respiratory conditions. And what I have learned out of these 5 years that I've now been a palliative care physician is that though we feel talking about emergencies, talking about aggressive treatments, we feel is going to make the patient feel hopeless. Oh no, now there's nothing left for me to do. I was coming to you for treatment. Now you're talking like this. It does make a difference the manner in which you talk to the patient, when, where, how much you communicate. So it cannot happen, hello, my name is Rajam, I'm here to talk of quality of life, let's talk about emergencies. It cannot happen like that. Like Dr. Biju has always, he is the one who taught me first about communication. You have to form a rapport. One, two, you have to realize that patient is waiting for you to talk about it, but the way you talk about it, the gentle, because he's experiencing all that nonsense that's happening to him. Cannot walk to the toilet, cannot breathe, has to walk with an inhaler, cannot think or plan any holiday. His life is miserable. He's waiting for somebody to ask, are you coping? What is wrong with you? What have you given up? How can I help you? What do you think will happen in emergency? So what do you want to do in an emergency? It's very important, because ideally speaking, again, in a resource crunch country like ours, we have few ventilators in the ICU. We need to choose the right kind of patients to go on the ventilator so that we make a difference to their lives. We save the patients we save, and we comfort the patients we can't. It's very important. Not everybody needs to go through that, what we say as a conveyor belt. ICU, casualty, ICU, ventilator, dialysis. Everybody need not die like that. There can be nicer stories, and we can improve our patients' quality of life. So these two documents are very good reads, where they tell you when to start discussing palliative care with your patients. It is not very often hospital consultants say talking palliative care is giving up, which is wrong. It really does make a difference to patients if they also feel that you care about their suffering, and they also feel that you are concerned about them. One last point is about the son in the US wanting to spend money and continue the aggressive treatment. I'm sure Dr. Biju can say we all have gone through this. My only question to the son is, what will you do, God forbid, if tomorrow you are in that place? And the answer is on his face. I don't want to go through it. But how can I let? So it's guilt. So I think Dr. Biju will be better to answer. But it is seen very often. I have the money. I can have the resources. Let me spend everything to keep my father alive. So we really need to deal it with emotionally. But I'm sure Dr. Biju has a much nicer way to answer that.
You are just bang on target. Regarding this, somebody saying, doctor, money is not a problem, do everything. That is something that we often come across. We have to remember that they are hanging on to what they have. That is, they have some connections. I know so and so minister, and so these are the way they are coping up with their distress. They're coping up being money is not a problem and things like that. Basically, it is about keeping your cool. And as Dr. Rajam said, it is an emotional, it's a highly volatile emotional situation. And we have to use the same emotion to make them understand. This is something that we often do when this issue of force feeding comes in. Some people, they simply just want to feed the person, who is in the state of anorexia cachexia syndrome. Similarly, somebody says that ICU, do everything, doc, for my dad, fix him, and things like that. So basically, what I just mentioned earlier, when we do something for the patient who is critically ill, the heart stop, you do this pumping, and if you do it properly, at least 2 ribs should be broken. And if the person stops breathing, you shove a tube down the throat and finish come to a machine. All of this emotional, all of this physical torture, you can justify. The emotional torture of keeping the family and the patient away, you justify. The financial torture, you justify. But if you can't save the person life, then how do you justify torturing that person? This is exactly what I asked the son from USA who wants to spend money. And then reason dawns on them, because I have actually touched the emotional raw nerve which will make that person think. And it is just a matter of 15-20 minutes of counseling and 180-degree change in the attitude of our family members.
And I think there is some research, if I find it, I will definitely share it, about the way the bereavement is in these complicated deaths. We don't follow up our families of who they lost their loved ones. People who lose it with all this action and unnecessary life-sustaining treatment have a much more complicated bereavement period. Which we also in palliative care keep in touch. We always contact families who have lost their loved ones to just know if they're coping well, or they're going through complicated grief and bereavement, like we did even during COVID times. Because COVID times was another level of grief. They couldn't see, they couldn't be bedside. So, but it really does affect relatives who live on. And because, like Dame Cicely Saunders said, the manner in which you lose your loved one is etched in those who live on. So it's very, very important to realize that it is important for each of us to experience what palliative care can do to your patients and therefore their relatives, and therefore not just the quality of death, also of how these people live on with what kind of emotional baggage.
Thank you, both of you. One quick question to Dr. Raju from Dr. Kiran. I'll shut up after that. Would we have given opioids as palliative care physician for 2 years in this patient?
So opioids is nothing to do with number of years of COPD. Again, like palliative care, it is need based. So if your patient is on all optimum treatment, you have tried the non-pharmacological methods, physiotherapy, handheld fan, and patient continues to be breathless at rest with a poor quality life, which we term as chronic breathlessness syndrome, is an indication for low dose, safe opioids. And please do evaluate your patients after you prescribe. Don't prescribe and forget the patient. Maintain a record of which patients you've given morphine. Call those people, tell your residents to call and see if it has made a difference. Then you can titrate the dose according to the optimum levels. And like Dr. Johnson said, we never ever go beyond or need to go beyond 30 milligrams in 24 hours. So very, very important to remember that also.
Thank you. I think Dr. Shilpa had a question on medical legal implication on withdrawal, but we have an extensive session in the end, just focusing on that. So we'll take up that question during the end. So I think it's time for us to wind up today's session. Thank you so much, Dr. Biju, for the wonderful session as always. And we are looking forward for the next session, which will be more about complex communication.